Well, thank you very much, Madam Chairman. Good afternoon, ladies and gentlemen. This is quite a big topic, and I can only just touch on the surface of it and give you a bit of a flavour for what's going on in radiology. I would like to say right at the outset that I am a clinical radiologist. I'm not a geneticist. But I think that this is perhaps one of the most exciting fields that we've seen develop in my lifetime, on a par with the development of magnetic resonance imaging, for example. I think this is certainly going to transform the work that I do and the whole of radiology. I thought we'd better start off with a few definitions, although I'm sure you've heard most of these before, really. So when I talk about precision medicine, or personalized medicine, I'm really talking about a personalized prediction of relevant tumor markers. Generally, we're talking about tumors here, although there are applications of AI to many other spheres of radiology and medicine. And using that to be able to give a personalized prognosis and to advise on specific treatment recommendations based upon the likely response of that particular patient. In terms of what we mean by artificial intelligence, I know it's tedious to actually read these out, but I think it's quite important. Artificial intelligence is the branch of computer science devoted to creating systems to perform tasks that ordinarily would require human intelligence. And subsets within that are machine learning, which is the subfield of AI in which algorithms are trained to perform tasks by learning patterns from data, rather than by explicit programming. And I say that because, of course, for many years in radiology, we've had CADs, we've had computer-assisted diagnosis in areas like CT of the colon or mammograms. But here we're talking about a system that actually learns as it goes along. It learns from the data as it analyzes those data. Deep learning systems encode features using an architecture of artificial neural networks, and they are particularly helpful in processing images. And we particularly use a deep learning architecture known as convolutional neural networks, CNNs, and that has really become the dominant deep learning system, I think, that's used in much of radiology and the research done. Of course, we've only been able to make any progress in this field because of three main factors, really, which have enabled the training of these large neural networks. Firstly, the availability of large quantities of labeled data, and the UK became really the first country in the world to have completely digital radiology back in the 1990s. The availability of inexpensive and powerful parallel computing hardware, and improvements in the training techniques and architectures. I've put up this little diagram to make it perhaps seem a little simpler how these different areas or different terms relate to one another. So it's really machine learning and deep learning methods that are being used for radiomics research. And it's radiomics research, really, that is the most exciting field in artificial intelligence for radiology. It's this area that is going to take the longest to come to clinical fruition, I think. But there's no doubt that it's this whole area of radiomics and radiogenomics which is going to transform practice and relate to personalized medicine. So in terms of what I mean by radiomics research, we're really relying on the fact that digital images are no longer just pictures which someone like me as a radiologist will come along and interpret visually. They are a huge and rich source of digital data. And radiomics processes, it processes the high throughput extraction of various quantitative features which I can't appreciate as a radiologist with a naked eye. So all sorts of different vectors are taken into account to produce a radiomic signature. And in this way, imaging data are converted into a whole area of mineable data that can be combined with other patient data, including the genomics, including clinical features, biochemistry results, histopathological results, and so forth. And using AI and machine learning and statistics, the data mining allows different patterns to be discovered within large data sets, which as radiologists, as doctors, we wouldn't know were there otherwise. And therefore, we can build upon all this, this precision that we can get out of the data to help us with the diagnosis and prognosis, and as I said, the therapy prediction and the response to treatment. So we've learned a lot over the last 20 years or so about tumour behaviour, which on first sight isn't apparent to a radiologist like myself doing a biopsy, for example, on a lung cancer. Because generally speaking, in clinical practice, if it's easier for me to, more accessible for me to biopsy a metastasis from that lung cancer rather than actually putting a needle straight into the lung with the risk of pneumothorax and so forth, then I'll biopsy the metastasis. But of course, what we know now is that tumors evolve with time, and their genetic evolution is very important. So we might well start off with a primary tumor, which is composed mainly of these red cells with particular markers on, and then with time it will progress and a different clone of cells will grow up, and of course the metastases can also differ. So we're going to get very different results if I biopsy this tumor at time 0 or whatever, and then 6 months later biopsy it again. I may take one clone of cells, or I may take another, or there will be different proportions. And of course, if I biopsy the metastasis again, I will get a whole different set of markers. So that's actually very misleading, and it's giving us a very narrow picture of the malignant disease in terms of the whole body load. When it comes to actually designing and making these radiomics algorithms, it's really a 4-step process which starts with the imaging, whatever that imaging might be. This happens to be a plain unenhanced CT of the thorax showing a cancer of the esophagus. That's the esophagus with a very thickened wall. And so you take your imaging data, and those data are then segmented out, which can be more or less easy depending upon how well the tumor is defined. Often that's on a semi-automatic process whereby we're helped by various algorithms that will recognize a difference in tissue density. And then the radiomics itself is, as I've said, a whole series of different vectors or features within those imaging data that are filtered and drawn out of the data, and there can be several hundred, and then manipulated into model building, whereby different combinations of features can be put together using statistics to give us various AI algorithms that can be applied to that particular patient. So traditionally, if faced with an abnormal chest X-ray as this one, I may note an opacity here adjacent to the heart, to the cardiac silhouette, which I may well be suspicious represents a lung cancer. I'll then proceed to a CT scan, and indeed we see that there's a large mass. Here are the lungs, that's the front of the patient, that's the vertebral body, and this is in cross-section, obviously. And we see a large mass that happens to lie in the apical segment of the right lower lobe, and it abuts the posterior surface of the oblique fissure there. And as a radiologist, I would describe that. I would say where it was located. I would say that from its position and its appearance on CT and the clinical history, this is likely to be a lung cancer. That's what it would look like on the mediastinal windows. We will then try to assess its staging, how far it has it metastasized, because obviously that will make a big difference to how that patient will be managed, how that patient will be treated, whether the patient will be fit for surgery. So we may well proceed to do a PET CT scan. So this is now a coronal image of a PET scan of the patient, which shows that there is very avid uptake of FDG tracer here in the primary tumor, but in fact there is no nodal uptake in this particular patient, and there are no metastases in the liver. So that patient would actually be staged as being N0 disease. There are no nodes, and indeed M0 disease, no metastases. So generally speaking, in lung cancer and in most cancers, it's the presence of lymph nodes that determine the likelihood of distant metastases around the body. And so we use that to determine what kind of treatment the patient is going to receive. Is the patient fit for surgery? What sort of chemo they will have, and so forth. Obviously, I will then biopsy the tumor, and we will characterize its antigens. But the other thing that we know is that of the node-positive patients, a very considerable proportion of those, in fact, don't go on to get distant metastases. And this is actually very important because it means that what we're in effect doing is over-treating many patients, assuming that they are in the high-risk group for getting distant metastases. So what we now need to do as doctors and radiologists is actually undergo a paradigm shift when it comes to cancer risk profile prediction. So we need to move from what we're doing at the present time, which is describing the morphological appearance of the tumour and making deductions about what the prognosis and treatment options are from the appearance of the tumour and from biopsying it and characterizing it into its histological cell type. And we need to move from that tissue cancer risk profile prediction to molecular risk profiles based upon the antigens expressed by the primary tumour and its nodal and distant metastases, if there are any. So this cancer risk profile paradigm shift that I'm talking about is really a question of moving from what the tumour looks like to what the genes in the tumour look like. So it's the genetic mutations we now know that actually drive the tumour's behaviour and drive the tumour's behaviour in that particular person in their genetic setting. So in order to actually perform precision medicine or personalised medicine, we obviously want to try to give that patient the best treatment for their particular tumour in their particular genetic makeup. And we want to try, above all, to avoid unnecessary over-treatment, which is what we're doing all the time at present with our cancer patients, because obviously these chemotherapies are really very toxic, they're very unpleasant for the patients to endure, and we want to save those patients who don't need to have them from having to undergo that kind of aggressive, unpleasant, long-term treatment. Also, of course, these drugs are very expensive, and so in terms of actually saving money, we don't want to be over-treating patients who don't need the drug. So knowing the genetic mutations becomes absolutely the key factor in treatment. And so really this is where the whole of the emphasis now is in research into imaging, and in particular cancer imaging. And for those of you who are not geneticists in the audience, if there are any other radiologists or any other jobbing clinical doctors out there, I just thought it might be worth putting up a quick slide, a quick diagram to talk about how, in very simplistic terms, immunotherapy works. So if you have a tumour cell expressing an antigen, normally the T cell would come along and recognize that antigen with its T cell receptor and kill it, but it can't kill it because, generally speaking, many of these tumour cells express a PD-L1 antigen, which binds to the receptor on the T cell and actually prevents that T cell from killing the tumour cell. I told you it would be in simplistic terms. So the aim of immunotherapy, next, is to administer to the patient substances that are going to recognize and block the PD-L1 antigen on the tumour cell, or alternatively, block the receptor on the T cell, so that in fact those two are not engaged, and that liberates up the T cell to kill the tumour cell. So in terms of what we're hoping for the future and what people are working towards using artificial intelligence, radiomics, to be able to help us with making a personalized diagnosis, prognosis, and treatment plan for patients. You could take this example of another CT scan of a patient's lungs, where you'll see that there are a number of small white dots which are abnormal, but there's one larger one and one smaller one here, which happen to be both metastases of a primary lung tumor. So from radiomics, without actually having to sample those very small, in fact, metastases, we will hope to, in the future, come up with a profile such that we can say that this metastasis from what is known to be a non-small cell lung cancer expresses these various markers and in these percentages. So it might have high PD-L1 and EGFR and BRAF, for example. And from that, one can predict the type of immunotherapy that would be useful to give to that patient. But of course, that is not to say that the lymph node metastases that this patient also has are going to express the same markers. So the lymph node metastases from this non-small cell lung cancer may well express markers in a different proportion. So perhaps a rather lower PD-L1 and EGFR and also KRAS positivity, which will actually obviously affect the most appropriate therapy for that particular patient and his or her lymph node metastases. But in order to characterize what these lymph node metastases might respond better to, one actually needs to know what the profile is of the antigens in those lymph nodes, and they may well, as we've seen before, differ. They differ with time or differ with site and so forth. And so one would hope that an AI profile of radiomics can actually tell us the degree of heterogeneity within those lymph node metastases, and that would enable us to biopsy the appropriate one. And it would be best, obviously, to biopsy one with the most heterogeneity so that you get the most different antigens and you get a better idea of what that treatment spectrum should be for that patient. So that is what we're hoping to achieve. We're not anywhere near that stage yet, but I'm just sort of giving you a model of 2030, for example, as to where we may be at. But where a lot of work has been done, where positive results are being obtained, is in the whole area of radiogenomics of glioblastomas, neural tumors. Now, it's very interesting, actually, that these glioblastomas have been completely re-stratified in terms of their classification. So when I started training in medicine and in radiology, all we could do really was to describe the morphological appearance on scans, generally on MR scans, of the different types of neurogenic tumor. So, we would use terms like oligodendroglioma, astrocytoma, glioma, glioblastoma, and so forth. But now, glioblastomas have been subdivided, hinged really upon the presence of mutations in isocitrate dehydrogenase, IDH. So you've got this sort of divide between IDH wild-type gliomas, which have a very bad prognosis, and they do tend to show the kinds of aggressive features that we were picking up or can pick up on an MR or CT scan, often with sort of infiltrative edema and a marked enhancement pattern, but not always so. And then the other main type of diffuse gliomas, the IDH mutant type, which in its extreme form with the IP19Q co-deletion would form this group of previously called oligodendrogliomas with progressive aggressivity as you move across the spectrum. So that's a complete sort of redefinition of how we classify these tumors, depending upon whether they're IDH mutant or IDH wild type. So there are a number of groups who are looking into introducing AI in the analysis of gliomas. And Chang and his group have applied convolutional neural networks, CNNs, these deep learning networks, to conventional MRI sequences. And they have been able to use these to differentiate IDH mutant gliomas from IDH wild-type gliomas with 92% accuracy. Now, that is very promising. So this is without going anywhere near biopsying the tumor itself. So, in other words, we can augment the human observation, which radiologists would previously have provided, and that's all we could have provided, to say, well, actually, we note that the IDH-type, wild-type tumors tend to demonstrate more infiltrative patterns of disease. They tend to have ill-defined margins. But using an AI algorithm, I like to think of artificial intelligence as augmented intelligence, really, because it's not going to replace us as radiologists. It's going to help us in our work. We can get a whole radiomic signature by placing a cursor over that tumor on the MR scan, because vectors can be extracted from those very rich data within the MR scan or the other digital imaging scans, from those MR images, which I can't detect with the human eye, and will include a whole range of different things such as texture and cell density and so forth, which will be able then to help us to characterize the actual tissue type of the tumor. Another feature, which is rather disheartening for radiologists, which is shown by gliomas, is this phenomenon of post-treatment glioma pseudoprogression, which all depends upon the tumor microenvironment. So what quite frequently happens with these gliomata is that you can do a post-operative MR scan, a baseline MR scan, for example. This is a flare sequence, this is a contrast-enhanced sequence. And then treat with completion treatment of radiotherapy and chemotherapy. And then 4 months or a period later, you can actually get a scan which looks a whole lot worse. And the problem is you don't know whether it looks a whole lot worse because the tumor has actually progressed and grown, or because you've got this phenomenon of pseudoprogression, whereby you've actually got an infiltration of immune cells into that area, which are actually killing the tumor, and maybe the patient's actually responding to the treatment, and also surrounding edema, as you see on this T2-weighted image here. And you can even get completely spurious contrast enhancement, spurious in that it may not be being taken up into a progressive tumor. So what we want to use AI for here is to do a virtual biopsy, really, so that we can distinguish true progression of the tumor, in which case, of course, we'll need to change that patient's treatment because it's not working, from pseudoprogression, in which case we would continue the treatment because it is working, and obviously there'll be mixed responses in between. So here's another example from a different group of pseudoprogression of a metastasis, in fact, to the brain. It was a melanoma metastasis. So this patient was treated, and then on the first follow-up MR, again, the appearance on this scan here is a whole lot worse. And we don't know from that, just from that at that stage, whether this is pseudoprogression or whether it's real progression. But it turns out that it was pseudoprogression because actually when the second follow-up, perhaps 6 months later, shows that in fact there isn't a large tumor under that area on the same treatment. So what Nguyen Kim's group has done in the Netherlands Cancer Institute, this is a works in progress, and I just heard about this at the European Congress of Radiology. It was presented last week, in fact. Is they have developed an AI algorithm which can actually identify the underlying cellular texture. So it's able to distinguish what is edema and cellular immune infiltrate from what is residual tumor here, or tumor necrosis. So obviously this is going to be massively helpful to us, and it's again a way of personalizing treatment for that particular patient on that particular scan. So here we're faced now in imaging with a second paradigm shift. So now we're moving from imaging the organ itself to actually imaging the tumor microenvironment around that organ so that we actually know what is happening through AI, through using these AI algorithms at the molecular and cellular level. So Roger Sun and his group published a paper in Lancet Oncology where they were using radiomics to assess response. And they took a group of patients with advanced solid tumors, and from that they were able to develop and validate a radiomics signature which predicted immunotherapy response. And in doing that, they used a combination of contrast-enhanced CT images and RNA sequence genomic data from tumor biopsies. And they were assessing the degree of CD8 lymphocyte tumor infiltration. And what they found was that the radiomics signature differentiates between tumors that are highly immune inflamed and those that are not. So in other words, they were able to tell from this algorithm that if there was a high radiomics score, that meant that there was a very high infiltration of CD8 cell infiltration, and that there was, in other words, that the tumor was responding to the chemotherapy being given. And it was able to show that which tumours responded better to anti-PD-1 and anti-PD-L1 treatment, and so in other words, which tumours were going to do better clinically, and which patients were going to show a better response. So here's the graph from that paper, just showing overall survival here against time. And so we can see that there's a better survival with time on those tumours that were showing a high radiomics score with a high CD8 infiltration compared with those that were showing a much lower radiomics score and a low CD8 infiltration. So here again, we're seeing actual imaging, if you like, of the tumour environment, the cell types that are within that tumour environment without having to do a biopsy, and extracting more data than the human eye can possibly assimilate from the scans that have been acquired. Then there's some nice work produced by Frederick Bench, published in Nature Medicine last year, where they used zirconium-89 labeled atezolizumab, I can never say that properly, which is in fact an anti-PD-L1 antibody. And they found that the clinical responses in patients correlated much better with the pre-treatment PET signal, or the PET imaging, than they did with immunohistochemistry from actual biopsy samples. And I suppose in a way that shouldn't really surprise us, bearing in mind what we know about the heterogeneity of molecular expression, varying from lesion to lesion and varying between primary and secondary and metastatic disease, and varying with time. So it basically showed that you had these two, based on the PET scan here, you can see the uptake of tracer, and looking at all the whole tumor, as it were, in the entire body, that you could indeed predict which patients were going to survive better without progression compared with those that weren't. Unlike taking a biopsy of one of those lesions, where in fact, and measuring histologically, histochemically, the PD-L1 expression, where in fact it was very difficult, it was impossible to determine the difference between those two groups. So all this work is really in its infancy, and as a clinician, I am very much aware that we are a long way off from this being introduced into routine clinical practice. And there are many, many challenges to artificial intelligence in radiology. I've listed a few of them there. One of the biggest challenges is actually getting good, high-quality ground truth data. So one of the issues is quite basic, really, and that is that depending on which particular MR machine you have or CT scanner, the data that you're acquiring will actually be different from a neighboring hospital where they may be using a different brand of CT scanner, and they may be doing their sequences differently. They're using different slice thickness, or they're using contrast at a different dose and so forth. So actually getting uniformity of ground truth data at a practical level is quite difficult. We also need to have very large annotated data sets. Well, you may or may not know that there's a massive shortage of radiologists in the UK, and therefore there's not going to be actually the workforce to annotate all those images to feed them into developing AI algorithms. I've mentioned about the uniformity of data acquisition methods as part of the high-quality ground truth data. And one of the issues, certainly for medical doctors faced with patients, really, is how generalizable and interpretable are these methods. So if you have all sorts of vectors being gathered for a radiomic signature, a radiomics profile, as ordinary clinicians, we don't really know what those are or understand them in any way, so we have no way of actually verifying that whether this was a good algorithm or a poor algorithm. And there's also been rather a lack, I would have said, of generalized, clearly defined tasks that we want AI to tackle clinically that are useful, so use cases. So that means that quite often different research groups will answer slightly different clinical questions, and comparison between the two isn't always easy. Regulation of AI in the marketplace is a total nightmare. MHRA haven't really yet, although they are responsible for regulating software algorithms, this is obviously a very, very difficult field. to regulate, and also when you bear in mind that we are talking about algorithms that are learning as they go along with machine learning, they are changing, and one hopes they're improving and learning from mistakes, if you like, but I mean, there's nothing to say that they might not be deteriorating. So this whole area of introducing artificial intelligence into clinical practice, which is going to affect patients, the regulation of those algorithms, and it's knowing what the data, how large the data set was that was used initially, where those data came from, knowing what the test data were, knowing what the validation data were, is all terribly important. And then, of course, assuming that we have got a really good and solid and robust and well-tested and regulated AI algorithm, actually integrating that into clinical practice so that when I'm sitting at my PACS workstation reporting and dictating digitally and so forth, that I can just easily apply the AI algorithm within my digital workflow. I'm not having to get up, go to another workstation, or take those data and put them somewhere else and so on. So integrating the entire thing into clinical practice is very important. So in summary, really, the imaging research aim now is to use imaging to look at what is happening at gene level. And to do this, to use artificial intelligence to look for radiomic signatures that are linked to significant gene mutations, because it's those gene mutations which drive cancer growth. And the way forward is undoubtedly going to be by the integration of artificial intelligence-powered imaging with molecular signatures and using those accurately to predict clinical outcome and thereby to guide precision medicine. Thank you very much.